the slides. So I thank him for those, and hopefully I can do it justice. So yes, Anna, I'm an anaesthesia fellow at St Vincent's Hospital, and I think pain management, in particularly acute pain management, is very important, particularly for the intern, which I found it quite challenging remembering back in those days. I don't think I'd ever actually prescribed an opioid or had thought about it at any point, and you're sort of thrown in the deep end, be that in the emergency department or on the wards. And it's good to know a little bit about them practically, rather than just from the pharmacology side of things. So the lecture outline tonight is how to sort of assess pain, which I'm sure that you're all very well versed in. Medical schools tend to teach this quite well, and more just targeting a targeting assessment of pain. Analgesics that are available, both safe ones that are available on the ward, and then other alternatives which will sort of prompt you to escalate to acute pain services or addiction medicine to support you, and recognising there is always a lot of support available in the hospitals. And I don't have a lot of experience outside of hospitals, been predominantly in hospitals all of my training, but certainly there's support available also in general practitioners as well. You're more than welcome to call the acute and chronic pain services at the hospitals, ask for advice. And there's a couple of scenarios Stuart has at the end, which I think are really relevant ones, and that you will almost 100% get in your first year as an intern as well, having to do emergency, general surg and general medical rotations. So firstly, on assessment, the history, I think, is very important and helps you prescribe a safe analgesic regime. I think it's really important to lean back on that Socrates history, which I did have to revise because you sort of do it a little bit automatically nowadays. And I think its acronym stands for site, onset, character, radiation, associated features, time, as in time course, which is very important to elucidate, and exacerbation, relieving features, and severity. Severity is something that the pain team really looks at post-operatively in progression for essentially de-escalation of pain management. And that's something that can be assessed in a number of different ways, but we'll touch on that later. Then examination is important to a point, and I think it needs to be targeted not only to be able to figure out exactly what's going on in a relatively short amount of time without causing the patient too much further discomfort, but also you can spend a lot of time doing a full examination when you've got like 10 patients who are in a pain crisis on a Friday night shift, cover shift. So first I thought I'd just put in the IASP definition of pain. This is an International Society of Pain. It's continually been updated, and this is the 2020 version. So it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Very vague, or sounds vague definition, but from what I take from that is that it's not only a sensory or somatic, visceral or neuropathic pain, but the emotional experience often is what needs to be considered and managed in conjunction with the actual tissue damage that may be occurring, and that recognizing that early on can really help you manage pain in patients with difficult pain management situations. So the cardinal features that I guess it's good practice to firstly when you attend a patient to take your history, always take the history, examination, investigations. We still recite that in our fellowship exams, so always do it, and it will stand you in good stead because when you need to ask for help, these are the things that the acute pain team will be asking, and it's nice to have that neatly packaged, ready to go to assist them with giving you prompt advice to be able to support you as quickly as possible and alleviate the patient's pain. So the cardinal features that we've recognised to be particularly important is the quality, and it's good to identify the type of pain, sharp, localised versus poorly localised and dull, as this can target different types of pain medications that will best manage this patient at the time. Neuropathic pain is also something that's been well recognised now, and we have some targeted medications to help with that. However, in the acute setting, it's generally well treated with similar medications to the somatic and visceral pain medications. Severity scoring is 0 to 10, and that's typically what people say, and that's how the nurses communicate, and it's a good research tool. However, it's not always clinically relevant, and the patients can get frustrated by grading their pain, and some don't understand it depending on a number of features, including language barriers or intellectual variations in intellectual abilities. And so it is good just to try and recognise the patient's background and figure out how best to grade their pain. And it's mainly just to get a baseline so that you can see whether this is progressing, worsening, or improving, whether your treatments are working or whether the pathology that's causing the pain is progressing. So terms that are used, and I like what Stuart has suggested here, is that are you comfortable enough? Some pain physicians and anaesthetists alike avoid using the term pain. I don't really have an opinion on that at the moment. I think I do avoid the word pain in patients whom I think may attach a negative or may attach quite a lot of significance to that. So using terms like, are you comfortable? How comfortable are you? If you were at home, would you take some Panadol for this discomfort or for this burning sensation or for this fullness in your stomach, or sort of use their terms that they've described rather than continually saying the pain. I think there was some research done saying that using the term pain over and over can actually increase someone's pain scores. So just think a bit laterally there and really make it unique to the patient, how you're asking it. Ability to function is very important, and it's something we use a functional assessment score on the pain round daily or twice daily. And that we've got eat, move, sleep, deep breathing, cough. It's more just, can they walk? Can they go to the toilet? Can they take part in their relative personal activities of daily living? And that's important because it guides not only the pain management, but also discharge planning and ongoing care. And importantly, when you're seeing someone on the ward for pain, and often it will be a pain crisis, and I think as an intern and resident, I found that the most challenging is the old pain crisis. It's a really challenging assessment, or at least a page to get. And I think it's important that in the acute setting, which is usually what you are, in acute pain or perioperative pain, to consider pathological causes. My approach to an acute pain crisis call is sort of structured into an immediate management, a short term, and then a longer term management plan. The immediate management is to immediately alleviate or de-escalate the situation. And that's generally by verbal de-escalation in terms of reassurance and reassuring the patient that you're here and you're able to deliver pain medications and prescribe it, and that you recognise that they are in pain. It's always very important to acknowledge that the patient is in pain, as pain is a subjective experience. It is independent of the doctor's opinion as to whether the intervention or the the operation is painful. It's whatever the patient calls pain is pain, and it's really important to recognise that early on. Patients very much appreciate that you recognise that they are in pain, irrespective of what the cause is at the time. But always very important to recognise pathological causes and escalate early to your, be that surgical or medical registrars or the pain team to further assess that. So I see it in parallel. So once you're doing your immediate management, and then your short-term management is your history, examination, investigations, and a temporizing pain management plan. And we'll go through shortly as to what you can use for that. Then the longer-term management is follow-up of the investigations, escalation to the appropriate teams for review, as it is important to pick up things that may deteriorate. And the things that I'm thinking of, that I've had experience with as a resident, is compartment syndrome. That's a really relatively common one on an orthopedic rotation. Ureteric rupture with urine leaking into the retroperitoneal space, and that's just post following a urotoscopy and stent. These were all situations where it was after hours, escalating pain requirements, very difficult pain to control, and these are cases that you really need to consider anatomical or pathological causes of the pain. So the examination, again, I like to stress it's targeted, particularly in a patient that is in pain. I think it's important to do a targeted examination to get an idea of exactly what are those features that you need to communicate to the general surgical registrar or otherwise of the pain, rebound tenderness, peritonitic, etc. Pain on passive stretch, for example, for a compartment syndrome. So this is things that the orthopedic registrar will be asking you, and it's important to do that examination, but make it targeted. I don't think it be guided by how much the patient is able to tolerate. It is absolutely okay to give some pain relief and wait, and then do an examination as well, provided everything else is safe. I think that's very humane, and we'll talk about some onset times of action in order to do that. Vital signs are very difficult to interpret in someone who's in a pain crisis. They will be sympathetically driven, they will be tachycardic, tachypneic, and potentially hypertensive, and even potentially have a low-grade fever. And these can blur the picture of whether this is pathological or just poorly controlled pain. So take those with a grain of salt. Always take the most conservative approach and get on top of the pain and reassess and see what the trend is, rather than taking it just as a snapshot. It's very important to always reassess after you've instigated some form of management for pain. Abdominal and thoracic pain, I guess deep breathing and coughing is definitely key for seeing how severe the pain is, and more importantly, if they are unable to deep breathe and cough due to the pain, this will likely progress into subsequent complications like atelectasis and hospital-acquired pneumonia, hypoxemia as a result of that. And this is very important and something that pain teams are very interested in, to try and prevent those types of complications. And that's specifically in patients with, say, small bowel obstructions, or post-operative patients who've had a laparotomy, and patients who have fractured ribs, particularly topical at the moment, fractured ribs. And pain examination in a setting for an intern, I would not expect you to do a pain examination including allodynia and hyperalgesia. I think you're mainly seeing acute pain or potentially acute exacerbation of chronic pain, and if you do elicit these, that is, that's great. That does help guide our pain management, but to do a pain examination can take a lot of time, and you do need some equipment. So I wouldn't expect that in the initial stage. So the analgesic options that you have on the ward are oral, intravenous or parenteral, and blocks, which we'll talk through now. So Stuart's done a nice little table here. So simple stuff, pure opioids, dirty opioids, or otherwise opioids plus another mechanism of action that is not got to do with a mu receptor, and neuropathic agents. Then there's the intravenous, so bolus or subcut IM PCAs, or patient-controlled analgesia, which you'll see quite a lot of in the perioperative patients, and potentially on cancer wards or hematology wards, and intravenous infusions. The blocks are typically where the anaesthetist does the block, or the pain physician. These are blocks that you will, likely catheters that you'll have to not necessarily manage, but at least assess and escalate to the pain team or the anaesthetist involved to assist with further management, and often just removal. And we can touch on that if we get time. There's other things to keep in mind. Is always checking the anaesthetic chart is a very helpful way to guide your pain management and see what's happened, because often they will have documented things like intrathecal morphine, which is given in theatre, and then that lasts for 16 to 24 hours post-operatively. So the items that are in bold, importantly, are the ones that you will become more comfortable with prescribing on the ward, and then the ones that are not, as things that you wouldn't typically prescribe without senior advice. So firstly, the simple stuff, paracetamol, NSAIDs, and COX-2 inhibitors like celecoxib, paracoxib, which is an intravenous form, and meloxicam, which is sort of a mix between the two. The pure opioids, the most common being oxycodone, and that's the same as endone, just brand names. Morphine, oral morphine is certainly a suitable alternative for patients with allergies to oxycodone. And then there's the dirty opioids, tapentadol, which is quite a new opioid, doesn't have the serotonergic effects, and the tramadol, which is quite commonly used. And then the neuropathic agents, which you're probably very familiar with, the gabapentinoids are sort of the relatively new ones, and now being implicated in have a bit of street value, unfortunately, and have an element of dependence to them too. Clonidine is something that I particularly like. However, it does have its side effects, and there are issues with prescribing it on the ward. The side effects particularly being hypotension and sedation when it's on top of other analgesic agents or sedating agents. But it does have that triple effect of analgesia, anxiolytis, lysis, and sedation, if you see that as a positive effect. But I won't go too much into it at the moment, as it's generally a second-line agent that you would get advice prescribing. The problem with the hypotension it's not necessarily sinister, but it can mean a busy night of Met calls for you. So regular orders, and I would advocate for regular paracetamol. There's a lot of strong evidence out there nowadays to say that paracetamol does reduce opioid requirements, and I would always advocate for a regular prescription unless otherwise indicated. There are caveats to the paracetamol. I think we'll touch on them shortly. Ibuprofen, in young patients with orthopedic or bony pain, I would advocate for ibuprofen regularly, and also in patients who are post-cesarean section. Very important for them to have an ibuprofen regularly. Always put a time frame on that, so say for up to 5 days, and then review, and ensure you've reviewed their other comorbidities, which we'll touch on shortly. And celecoxib is now probably the most common anti-inflammatory used in orthopedic patients. It's 100 to 200 milligrams twice daily. Is a very safe dose for up to 5 to 7 days, and it's very effective and opioid sparing. And most of what we do is all for opioid sparing, and that's largely because opioids, one, have their side effects that can keep them in hospital longer: sedation, constipation, and nausea. And then they also have that, the ongoing opioid epidemic of high amounts of opioids in the communities that have been implicated in a number of unintentional overdose. So therefore, these tend to be PRN doses or as required doses, orders, and I would strongly advocate for only prescribing PRN opioids. The College of ANSCA, the Australian College of Anaesthetists, or Australian and New Zealand College of Anaesthetists have a statement that strongly advises against prescribing slow release opioids in the perioperative period, and I would support that, particularly as an intern and a resident. So I've mentioned that. Indefinitely higher doses, anything more than 10 milligrams would need to be reviewed. The problem is because we don't have a way of following up and stopping them. We need a strong communication with our GP in order for them to follow up and stop these or wean these medications. However, GPs, as you well know, are inundated, particularly at the moment, and for them to be following up these patients who've been started on slow release opioids to wean them is potentially unnecessary workload for them, and something that we can avoid whilst in hospital just by simply titrating their pain medications better. However, if they are already on it, just continue it in the perioperative period. Even when fasting, it's very important for them to have their medications unless otherwise advised. Paracetamol is important in pediatrics to always calculate the dose of paracetamol per their ideal or lean. I believe it's the ideal body weight, but if you're not sure, just do the lean. So i.e. the weight that they should be at that age, not the weight they actually are. We have a large number of obese children nowadays, and it's very important to recognise that their liver is still the age of the liver that they're at. It's a 3-year-old liver in a 50-kilo 3-year-old. So it's really important to dose adjust for the weight. In patients who are, Stuart has less than 60 kilos, I'd probably say less than 50 kilos, I would dose adjust as well. And you can ask advice from the pain team for this, but 15 milligrams per kilogram is typically the dose up to 1 gram and maximum 4 grams per day. Importantly, patients who are fasting for theatre have depleted glutathione stores, and so they are at higher risk of paracetamol toxicity, and this must be considered particularly in the surgical patients. And so always good to continually revise your medical chart on the morning ward round and figure out whether they are continuing on a safe dose of paracetamol. And with this, avoid altogether in severe liver disease. That comes with the caveat. Some patients in severe liver disease are very stable and can take paracetamol at reduced doses, and it can be very effective for them. So always just discuss this with gastroenterology prior to prescribing it. As I was mentioning before, the NSAIDs and COX-2 inhibitors are good for healthy, otherwise fit and well patients, which is typically your orthopedic trauma patient. The osteoarthritis patients also can fit into this group, just being mindful of any cardiac or renal pathology or impairment, as they can make the platelets sticky and more prone to cardiac problems, and they can reduce renal perfusion and precipitate acute kidney injury, particularly when combined with other medications such as furosemide and ACE inhibitors or ARBs. Patients who are potentially at risk of rebleeding, such as tonsillectomies, although this is controversial, should likely avoid the NSAIDs or the non-selectives. Celecoxib or the COX-2s are thought to be safe in this setting, but I would ask your registrar or consultant about that, or the pain team. but they are very effective. But again, ensuring that you have a time frame to them. They shouldn't be continued for long periods of time. I say 5 to 7 days. They don't necessarily have to be taken with food. The effect on the gastric mucosa is actually systemic and not topical, unlike something like doxycycline, for example, which actually does burn through the mucosa if it's resting in the esophagus, whereas the effect on the mucosa is due to the effect of the drug on prostaglandins. And so it doesn't necessarily have to be taken with food, which is important in some patients, particularly in the perioperative period. So pure opioids are dangerous drugs, and they're very important to have a good understanding of the doses, frequencies, and patients who you need to watch out for when prescribing them, particularly in your intern year, when you'll be busy, you'll feel pressured to get on top of someone's pain very quickly, but it is important to step back and consider their situation before prescribing the opioid medication. Oxycodone is the most common medication prescribed on the ward from an opioid perspective. Opioid toxicity or opioid-induced ventilatory impairment, OIVI, is our main concern, and it can lead to respiratory depression and not infrequently respiratory arrest. And the coroner's webpage, if you're interested, is full of opioid-induced ventilatory impairment reports, and it's an interesting read. The common themes that do crop up are those patients who are at risk of being more sensitive to opioids. So everyone has different levels of sensitivities depending on their genetics. So pharmacogenetics is a large area that's developing quickly. But, and we do know there are certain, the patient's age is a very big determinant of how sensitive they are. So the older they get, the less opioid they need. It's not a weight-based prescription. It is a age-based prescription. Elderly patients are have an elevated risk of opioid-induced respiratory depression. Patients who are obese, we know, have increased sensitivity, particularly if they have obesity hypoventilation syndrome, and if they have obstructive sleep apnea, they are much more sensitive to opioid doses, and they need to be dose reduced. Patients who have chronic pain issues and opioid dependency are also frequently mentioned in these coroner's reports because they have difficult to control pain in addition to having opioid dependence. And it's the combination of these often lead to a sort of a deadly triad or so that happens often overnight when they are not being monitored in the appropriate environment for the opioids that they're given. So it's really important to consider this, particularly when you're giving frequent high doses of opioids to a patient on the ward. Always really good to escalate early and call either whomever the home team is, the acute pain service, the anaesthetist, anaesthetic reg or anaesthetist on call, and intensive care. The intensive care registrars are very happy to be phoned about these patients. And it may even be safer for this patient to go to intensive care for closer monitoring. So these are all really reasonable considerations for someone whom you're not comfortable prescribing more opioids on the ward environment when they're only getting 4-hourly observations and they're not having continuous oxygenation monitoring or continuous line of sight monitoring. So please utilise those services. And we'll be happy to help. Don't combine opioids and benzos. This will be a difficult situation for you at night when you're asked to prescribe temazepam to all the patients who, who want to sleep. I used to call it my temazepam round. It is ideally do not combine them, but always, if you are going to prescribe it, it'll be a once-off dose as a stat dose, and always check what other medications they're taking and what other opioids are due that evening. particularly if they've had things like intrathecal morphine, which I'll talk about later. Tramadol is a really old drug. It's quite effective in some patients. It can cause nausea. It can safely be prescribed with another opioid, and usually is typically 50 to 100 milligrams Q6 hourly PRN, the maximum dose of 400 milligrams. Tapentadol is sort of a new kid on the block, relatively new. I've seen it quite widely prescribed at the hospital I'm working at now. Other hospitals don't have it as available. It doesn't have the serotonin receptor inhibition, so typically can be prescribed with antidepressant medications as long as they haven't got that noradrenaline aspect. I think desvenlafaxine is one of the SNRIs as opposed to the SSRIs. So just be mindful of that when you're prescribing it. There's interactions, drug interactions to be aware of, including that serotonin syndrome, but also it does lower the seizure threshold. So it's typically avoided in neurosurgical patients, in addition to patients with epilepsy. I would typically avoid them and get advice on those. They are quite emetogenic. It is important to always have an antiemetic prescribed alongside, and sometimes I would just encourage them to give ondansetron or an antiemetic prior to giving the tramadol. It makes it much more effective and much more pleasant for the patient. They are less addictive and have lower street value. Importantly, no active metabolites, which makes it for a slightly safer drug. But it's important just to consider the side effects. It is safe to prescribe tramadol and tapentadol with what's called a patient-controlled analgesia, so a PCA, which gives intravenous morphine or fentanyl or other drugs. So it is quite safe to have that as an alternative as well. These drugs to avoid in renal impairment. It's always good to consider. When we say avoid, I wouldn't necessarily completely avoid them. It's good to consider the pharmacokinetics and dynamics of the drug prior to delivering it to the patient, prescribing to the patient. Usually it's just a dose reduction, and I would be guided by your senior your team registrar or the acute pain service on this one. Pregabalin and gabapentin are typically continued in the perioperative periods, say for example. However, if their renal function declines post-operatively or during their hospital stay and they become drowsy, then it's really important to consider this as a cause of an overdose of or accumulation, I should say, of their gabapentinoid. It can make patients feel very drowsy, and it has been known to delay discharges due to those effects. So always keep that in mind. So these are the analgesics that you will use intravenous subcut IM for surgical patients, typically on the general surgical ward. It can be used outside of that in, say, the emergency department. Paracetamol, as I'm sure you know by now, can be given intravenously. It can drop the blood pressure somewhat, but it's quite safe on the ward given slowly. It's the same efficacy, and it's much cheaper to be given as a tablet. So if you're considering the economics of it, I would give it orally via tablet if possible. Tramadol is really good to remember that it can be given intravenously, and it has what's called the same bioavailability orally as intravenously. So it's the same dose. So you can actually write on the PRNs 50 to 100 milligrams Q6 hourly, oral/IV, and that gives the nursing staff some good options as to whether the patient is able to take oral intake or not, or whether they're nauseous or not. Morphine, subcut or IM, this is a good temporizing measure. I wouldn't say it's a good plan to have long term. I would use this as a temporizing measure, and 2.5 to 5 milligrams Q3 hourly maximum. The reason being is there's variable absorption of the morphine, and it can accumulate. Intravenous PCAs, so you'll see a lot of those. They're managed by the pain team. What I think you'll be asked to do is just take them down or at least cancel the order, but that's about the only management side of things you'll have to do with them. You cannot have oral opioids on top of that, so you can't be taking oral oxycodone as well as having intravenous oxycodone PCA. So it's important to note that. However, as I said, Tramadol can be given if they're on an intravenous PCA. It's good to get them off that as soon as possible. It helps expedite their discharge and get tubes down and stops you guys having to put in IV lines. Patients obviously have to have an IV with this PCA. Intravenous infusions that you'll see quite a lot of now is ketamine and lignocaine will be starting to come onto the wards, I reckon, in the next couple of years. It's just good to have a bit of knowledge around them. You typically won't be asked to review these, but it's important to know about their side effects, such as hallucinations with ketamine. Can be quite terrifying for the patient, and all you need to do in that setting is just dose reduce or pause the infusion and then restart it at a lower dose. It's all dose dependent as to what side effects they get with the ketamine. So if they're on typically 6 milligrams per hour and they're getting side effects such as scary dreams or hallucinations, you can dose reduce that by 50% to 3 milligrams per hour, and that can typically resolve their symptoms. Always provide reassurance to the patients when they are having those sort of side effects. It can be quite terrifying for them. Lignocaine infusions, I won't say much more about as they're not typically seen on the wards at the moment. Importantly, not to give intravenous opioids yourself or prescribe them at any point on the ward. It's only to be prescribed by someone who can intubate an airway comfortably. So I've sort of taken those. PCAs are very safe because they fall asleep and they can no longer deliver the opioid dose, but good to have a bit of a familiar idea about what they are, but you won't be expected to prescribe them. These are the blocks that we will do in theatre and can sometimes come do in a pain crisis if required. You're probably familiar with them, or at least somewhat familiar with the spinal and neuroaxial epidural, being thoracic or lumbar, and upper limb brachial plexus blocks, lower limb typically femoral or sciatic nerves, and then the trunks. Importantly, in the thorax at the moment is the erector spinae, which you'll often see being done, and I would expect hopefully you to refer to the acute pain team for us to support you with performing erector spinae catheter for rib fracture pain. Very effective and fairly low risk. Through those catheters. Abdominal, so typically in some laparotomy patients, they will have wound catheters such as a rectus sheath catheter, a transabdominal plane catheter. Again, these will all be managed by the acute pain service, but it's important to review them, be familiar with them, and they are delivering local anaesthetic. So something else that this talk doesn't cover, but I would be grateful if you could pop it on your list for homework, is local anaesthetic toxicity, as I think it's important as an intern to be able to manage or at least recognise local anaesthetic toxicity and escalate early, because often that's what these blocks are delivering, and on a ward environment, you will be the first responder. With the rib fractures, really important to check the hospital guidelines. A lot of the hospitals now, Royal Melbourne in Victoria has excellent hospital guidelines for that, and I would definitely support you following those guidelines. These are some afterthoughts. So the patients I found very challenging, and I still do, are patients who have opioid tolerance or opioid use disorders, and they need to be escalated to addiction medicine or at least the acute pain service for you to be able to effectively manage their pain. We can overshoot their pain management requirements quickly. They are at times unreliable historians, be that because they're under the influence of some form of a drug, or they perhaps may be opioid seeking. And that can put you in a position that not only makes you uncomfortable, but it means you can be prescribing medications and they may well not be reporting what they usually take accurately, and can significantly overdose them, or on the flip side, underdose them, and they can go into an acute opioid withdrawal syndrome, which is often presents as a pain crisis as well. So really important to get support with those patients. The drugs that you'll see will be methadone, which is typically sort of the older style management, and nowadays Suboxone is largely used, which is just naloxone and buprenorphine. So the fentanyl patches are very topical, that we're trying to phase them out as a management, not using them as management outside of any cancer pain. Cancer pain patients, they're quite effective for, but fentanyl patches are no longer indicated in acute pain management. Buprenorphine is a fabulous drug that if you do anesthesia or pain management, you'll become much more familiar with. It also has antineuropathic effects. It's a partial agonist, and I highly recommend it for particularly patients with an ileus postoperatively. However, it is something that you do need assistance prescribing, but we are more than happy to help with that guidance in the form of patches and in the form of sublingual. Ketamine, oral ketamine, you'll see probably used at the Royal Children's Hospital. They use that for burns dressing changes on the ward. It's quite a safe drug, maintains spontaneous ventilation. That has less of an effect on the respiratory centre. Can cause hypersalivation though. And as we're talking about hallucinations, it is really effective though sublingually for painful dressing changes, to avoid having to go to theatre to get anaesthetic support from that. But by all means, please call us if you need help. So it takes us to the scenario of not being able to take tablets, which acute pancreatitis is an incredibly painful condition. They have profuse vomiting as well, and we would expect them to be escalated and referred to the acute pain service on admission as soon as possible. They will require intravenous pain management, and we'd be very happy to support that. In the interim, when you are called to see them, these are the options you can prescribe. So the intravenous options we were talking about is paracetamol, 1 gram QID regularly. Again, the caveat to this is any hepatic dysfunction. They may well have a obstructive transaminitis in the setting of perhaps a gallstone pancreatitis. So be mindful just to always check the patient's history and apply the clinical scenario to what you're prescribing there. Tramadol is quite safe in this setting, and I would highly recommend that. And then subcut morphine, as we were talking about, is a temporizing measure until you have other alternatives recommended by the pain service. I think Stuart's got the slides at the end about antiemetics, but it's really important for patients to be also prescribed antiemetics at any time you're prescribing pain medications. Bowel obstructions, small bowel obstructions, large bowel obstructions, they will have a nasogastric in, and that will be on free drainage. So any oral medications are out of the question there. These are the things that we may prescribe. PCA is typically common, and ketamine infusion if we need to escalate from that if it's not well controlled. The scenario here is rib fractures that I've been hammering on about. So there's a really nice pathway in a lot of the protocols as to considering firstly the patient and their comorbidities, and specifically with a patient with rib fractures, if they have underlying lung disease, you need to consider that they will be a much higher risk of getting a complication such as pneumonia or atelectasis and requiring oxygen support. So any patient with underlying lung disease, COPD, or cystic fibrosis, bronchiectasis, these patients need to be escalated early to the pain service for alternative pain management. So always consider that. Consider the pathology. So how many ribs are fractured? Is there a flail segment indicating high energy trauma and likely underlying pulmonary contusion or lung contusion, which often presents 2 to 3 days later than the actual insult at the time or the trauma? And then are there any other complicating issues like bilateral rib fractures or sternal fractures, or an underlying pneumothorax requiring a chest drain? Or chest drains are very painful, and I would highly recommend them be escalated early. And so first things, but if it's otherwise an uncomplicated 2 rib fractures, you can easily start with oral analgesics, regular paracetamol, regular non-steroidals, and then I would certainly add PRN opioids, and I, again, would be gauged by the age of the patient. If they're a young, fit male with rib fractures from an isolated chest trauma, then you can safely prescribe PRN oxycodone 5 to 10 milligrams Q3 hourly. And I like to put a sedation score on there as the maximum dose, but I'd be guided by your hospital pharmacy protocol as to what you as to their maximum dose for the PRN opioids. I personally don't think there should be a maximum dose for opioids, because we know what when to stop is when the patient starts becoming sedated, because that precedes respiratory depression. So we stop giving them when the patient has a sedation score that's 2 or more, which the nursing staff routinely do prior to giving any opioid or any analgesic sedating agent. But definitely be guided by your hospital policies and protocols on that. We will typically prescribe an intravenous patient-controlled analgesia for a rib fracture patient who fails simple therapy or who has those risk factors I was mentioning before. The blocks that we will do, thoracic epidurals, you typically reserve for bilateral injuries, bilateral rib fractures. Erector spinae plane block, hopefully we can have maybe a session on blocks later, but that's a very safe block. The patient is able to be continue on their antiplatelet and anticoagulation medications, and we are able to do that in theatre. We leave a catheter in for up to 5 days. The patient does stay as an inpatient for 5 days, but it's very important that they avoid any complications like pneumonia. So we find it's extremely effective. They can have 2 in, and I've seen, a lot of good outcomes from these erector spinae plane catheters. So please feel free to call us if you think your patient may benefit from one. And as I mentioned, why it's all the fuss, because these patients, it is a big fuss, and it has been a huge hugely topical in the last couple of years, because these patients, young patients as well with severe chest injuries, do die from pneumonia and hypoxemia as a result of these chest injuries and underlying lung contusions and splinting due to pain. The problems, as you can see, it's a catch-22. We give more oral opioids and the patient becomes sedated. They become hypopneic, and they are in pain, so they don't breathe. So they don't expand their chest wall, and the medications that we're giving them are sedating them. So it ends up being in a spiral. So that's why we like to opioid spare in these patients in particular, with an erector spinae plane block using local anesthetic techniques. Importantly, every morning you see this patient, you need to ask them to deep breathe and cough, and the pain team will go through those a few extra things with them, but they can get a rolled up towel and to keep the rib fractures in place whilst they're doing that. Good, so we've gone over those few things. Paravertebrals is something that erector spinae are replacing. I won't go into much more than that there. So epidurals, important that you understand the red flags, and these are sort of the main ones we have out here. So a day 1 postal Whipple's procedure, which is a sort of major upper GI surgery. The patient is very comfortable, which makes your job and life easier. However, they've got a nice sensory block from T4 to S1, which is quite a broad block. However, they've got no motor function in the lower limbs. What will you do? So an epidural is inserted for sensory, to ablate the sensory or the pain fibers. We are not aiming for a motor block. If a patient who has an epidural on the ward has a motor block, so they're unable to move their legs, otherwise known as a Bramage score, but if they are unable to move their legs, then this is a red flag and this needs to be escalated urgently. So I wouldn't suggest panic. I don't suggest panic in any situation, but importantly, turn the infusion off, call for help, and that means call your registrar of your team, call the anaesthetic service emergently, do an examination of the lower limb and of the back, look at what's being given and what is going through the epidural, and then what may be done. So what the management typically of this is, we are concerned there may be an expanding hematoma that is compressing the spinal cord at the level of the epidural insertion, and that will require emergent decompression via surgery. So this is something that you need to escalate early and get guidance from, and you may well need to prepare the patient for an urgent MRI and emergency surgery. So take their dinner away from them. Reassure the patient, obviously, at the time as best you can, and always keep them informed of what's occurring. It is very uncommon to have an epidural hematoma, but they do occur, and so it's important to escalate early when that motor block occurs. Back pain after an epidural. So now it's the same patient, but they're 2 weeks post their procedure and the epidural's probably out by now, hopefully, and they're complaining of lower back pain and have a fever. Anyone who has back pain and a fever, it's very important to consider an epidural abscess, take blood cultures and escalate to the neurosurgical team or orthopedic team, whoever manages that in your hospital. So panicking, I wouldn't again suggest, however, taking blood cultures, and this likely will require an urgent MRI plus or minus decompression, long-term antibiotics, and wash out of the abscess. That's typically the course that happens in an epidural abscess, but again, it's just your role to suspect this, to take a thorough history, always be suspicious of back pain and a fever, and try and clinically correlate it with the patient's presenting condition. And in this case, they've had an epidural in the past, in the recent past. So it's important to communicate that to the surgical team. So in summary, we've talked about the patient assessment and the history examination, followed by investigations that you see fit after discussing it with a senior if you feel a scan is relevant, is indicated. The analgesics that we've spoken about, that you're comfortable prescribing, you will become comfortable prescribing on the ward by the end of your internship. Knowing the doses, the safe doses, the safe frequencies, and always dose adjusting to the patient in front of you, to the clinical scenario, both their past medical history, their social history, and the acute pain that they are experiencing, and trying to tailor it to each patient. It is not a one-size-fits-all, so it's important to tailor it. The neuroaxial complications of the epidural catheters that we've spoken about, that are again important to escalate early. So that's a hematoma. So it's when someone has a motor block on the ward with an epidural. That's very concerning. And then an abscess, which is often a more sort of subacute presentation. But fever and a back pain is very important to not dismiss. And as I mentioned before, we've got a couple of minutes left. So Antimedics, very important to always prescribe them when you're prescribing any opioid analgesia or any analgesia at all. There was a survey done on patients who were coming for anesthesia, so semi-relevant, and more patients actually feared postoperative nausea and vomiting than they feared death. And they actually feared postoperative nausea and vomiting in themselves more so than in their child that was going for an anesthetic. So it is a very important patient consideration, and you must prescribe antiemetics. Ondansetron is probably the safest antimetic to prescribe. Its side effect on chronic use is constipation, and you really only see that in patients who are undergoing cancer therapies or long-term ondansetron. 4 to 8 milligrams TDS. It can be given IV, PO, sublingual. It's a very safe drug. No more benefit giving more than 8 milligrams. Cyclizine is an excellent drug, however, it can cause sedation. It's also an antihistamine, so it can help with some of the itch that may be associated with morphine, although it's not recommended for it. It's not really many contraindications, so I would definitely aim for cyclizine. It really only comes, I thought it only came as intravenously, so just check that with your hospital. Metoclopramide is not a good antiemetic, except in patients with delayed gastric emptying. So I would steer clear of that. It also has some nasty side effects, particularly in young females. They're more sensitive to the extrapyramidal side effects, and I would avoid it. So I actually do not prescribe metoclopramide unless it is indicated for gastric emptying. Droperidol is excellent. However, it can cause what's called a locked-in syndrome if given in higher doses, or if there's a drug error, and it's quite easy to cause a drug error on the ward with these because it comes as a highly concentrated preparation. And so just prescribe that as second line. Prolonged QT, it's always good to consider that. It's mainly more relevant in pediatrics, in patients with congenital long QT, but all of the antiemetics prolong the QT. And that is the end of my presentation, and thank you to Stuart for that. Happy to take any questions.
That was awesome. Thanks, Anna, for that. It's good to know that we've got so many sort of drugs at our disposal to help comfort our patients, and APS is always there to back us up. We've just got a few questions from our Slido link. The first question is, why is oxycodone more commonly prescribed in the wards when morphine is a weaker strength opioid?
Weaker strength. So potency isn't something we tend to consider too much. It is certainly a drug property, but we're more concerned on the efficacy or the end point of what we're treating. So whilst morphine is slightly less potent, it doesn't mean it's any more safe, because we need to give more to get the same effect as oxycodone. So the other issues practically are that morphine comes in quite a concentrated solution, and we've had a number of issues with patients being inadvertently given dangerous doses of oral morphine because the solution was so highly concentrated that it was given undiluted or in the incorrect dilution. And it also is variable depending on what hospital you go to as to what dilution they have. Whereas oxycodone is very standard dilution, and it's much more familiar across to the nursing staff, and standard dilutions across the across hospitals. So we do tend to just use oxycodone and save the morphine, the oral morphine, ordenes, for patients who are already on oral morphine as a slow release. We will typically just keep them on the same opioid. We would also save it for patients who have adverse side effects to oxycodone, which there's quite a few out there, and they would prefer oral morphine. But it is practically, it's a higher risk PRN drug, purely because it's less commonly prescribed and has higher variability in the preparations that is out of our control, unfortunately, from the drug company perspective. We are often set up to fail or to make drug errors by the preparations that continually change.
Excellent. The other question we had was, when would you consider a MET call for a pain crisis, or do you just refer to APS?
So with MET calls, I think you can call a MET call whenever you feel a MET call is warranted. I would never discourage anyone from calling a MET call, and I would never buy into a threat of calling a MET call just to get you there faster. If a MET call is warranted and a nursing staff is referring to you for patients in a pain crisis, and they say they'll call a MET call, then by all means go ahead and call a MET call. It can only benefit the patient, as you know, there's obviously something that's precipitating this. So I wouldn't have a threshold for calling a MET call. I would use your gut feeling. And look, as an intern in your first couple of months, your threshold for a MET call may be very different to your threshold in a couple of years' time. And that's fine. And that's what they're there for. They're to prevent or to minimise further deterioration of the patient. So I would strongly support that. However, very happy, certainly in the hospital I'm working in, we have a on-call anaesthetic registrar 24/7. We're very happy to be, although we may not sound like it all the time, we are very happy to be phoned, because it makes our job a lot easier than catching up at a pain crisis and having to give sort of intravenous ketamine at a MET call, for example, for a pain crisis. It does add to the workload, which is fine, but it does mean we're sort of playing catch up, which a patient's pain is best managed if we can anticipate that and prevent those pain crises. But they will happen, and they are unpleasant, particularly for your first couple. But I want to reassure you that you are supported, and that and just try to do your immediate management to de-escalate the situation and provide some safe analgesia to control the situation, and then get senior advice.
Lovely. And the other question we had was, if a patient has allergies to codeine / morphine and endone, what options do you have? Can you use Depentadol / Tramadol?
Really good question. So when I hear that, I think this patient must have a history of some form of either acute or chronic pain, or opioid use previous, obviously, because I figured this out. So it's good to elucidate what the type of allergies are, and why they particularly, this patient does not prefer or is allergic to these medications. Some have allergies that are documented, such as nausea, and it may well have been during a time where they were having an acute bowel obstruction and they were given that, and that is obviously a very clouded picture. So it's really good to get a good history around those sort of allergies, and the context of which the patient first discovered those allergies. However, if they sound like pretty legit allergies, and you do need an alternative, then by all means, Tramadol and Depentadol are very safe. It is recommended not to prescribe the two together, so just pick one or the other, and prescribe a PRN dose initially, and then get support if they need a more regular or slow acting medication, because we always need to titrate just to figure out what the patient needs, essentially. So yeah, it's very safe to prescribe those as an alternative. But those patients can be very challenging. So always very happy to ask for help from the acute pain service with them.
Yeah, sounds good. The other one was interested to hear about slow release opioids. Tarjan is often prescribed instead of endone. I've been told to transfer daily requirements of PRN oxycodone to Tarjan.
So if you are interested in them, then I would recommend going on to the ANZCA website to read the ANZCA statement on this. It was, I think, probably 2 or 3 years ago, and they do not support the prescription of slow-release opioids for acute pain. It is a really difficult situation. It is certainly what you do is add up the PRN dose of oxycodone, divide that by 2, and then split the half dose into a BD dosing, and then have the PRN as the other dose. So, sorry, I don't know if that makes sense, but that's your way of converting it. But this does make for people going home on slow release Tarjan, they become opioid tolerant and potentially opioid dependent very quickly. And this then puts a large burden on the community and a high amount of opioid in the community that can then lead to those opioid unintentional overdoses that we've seen. So I would strongly recommend against prescribing slow release opioids without senior advice, including that from your registrar, your consultant, or the acute pain service, particularly given the ANSCA statement does not support them. So you may open yourself up to risk that is unnecessary. If you are requiring a slow release opioid because of the pain, it's important to get the pain evaluated, and then it's important to also, I would say, just to increase the availability of PRN pain medications. For example, a typical PRN dose of oxycodone is 5 to 10 milligrams Q3 hourly. If that patient is maxing that out in their 24 hours, you can then increase that to 5 to 15 milligrams Q3 hourly, or 5 to 10 milligrams Q2 hourly. And with the caveat, this is my practice, again, depending on your hospital, is with the sedation score, that has to be less than 2. So they must be awake and alert enough to ask for their medication.
Sounds good. And thank you everyone for submitting all your questions. We've probably got time for only one more, unfortunately. The last one is, how does long-term in-hospital pain management differ from short admissions? Anything else we need to look out for over the long term?
I'm just wondering how to interpret this. So this is for a patient who's been in hospital long term.
If someone, whoever asked that question, if you want to unmute yourself and clarify what you meant.
Just wondering if it's for a chronic pain patient who's in hospital for a long period of time, or...
I'm not sure. That's all right. We'll move on to another question.
Just for long-term hospital. Oh, okay, right. So that's a good caveat to the slow release opioids. So sometimes patients at a trauma hospital, for example, will be in for a long time. They'll have a long intensive care admission, and then they'll be transferred to the ward. These patients will be seen by the acute pain service. Sometimes these patients will be on slow release opioids because usually because of their intensive care admission. They're often on IV opioid infusions whilst they're intubated, and they often become opioid tolerant, and in which case we then need to transition onto oral slow release opioids to avoid acute withdrawal syndrome, but also to be able to manage their pain. So they are complex. They should be managed in conjunction with an acute pain service. And on discharge, they will likely be on a slow release by the time they get out, which is usually 3 or 4 months' time. And it's just very important to liaise with the GP and to have a written well-documented discharge plan that has been agreed upon by yourself, the patient, and the GP. And often the acute pain nurses are very good, particularly the trauma service I've worked at, are very good at following up these patients and helping them wean off their opioid.
Excellent. Well, on behalf of PVACCS and everyone here tonight, I'd just like to say a big thank you again, Anna, for spending your Thursday night to teach us about pain. I'm sure we've all taken away heaps of clinical pearls to use in our clinical practice. So thank you so much.
Not a problem. Thank you for the opportunity. Yeah, I'm very happy to take any other questions via email or otherwise. And I look forward to coming across you all at some point during your training.
Amazing. And to everyone else, thank you all for tuning in. We're holding a careers night next Tuesday. We've got a couple of ICU and anaesthetic consultants who will be talking about their careers. So just check our Facebook page to find more information. Also, if you've got any feedback about our events this year or what you want to see next year. There's a feedback form in the chat, so just let us know when we can bring you better events for next year. So thank you again, everyone, and have a good night.